US. And on behalf of the GardaWorld, our hundreds of healthcare leaders across the country and North America, and in particular, our frontline security officers in our healthcare facilities protecting our patients and staff. This webinar panel discussion supports our mantra, which is supporting a safe and secure environment of care, allowing our clinicians to provide exceptional care, the patient to heal, and also contributing positively to the overall patient experience. The important topic of violence in healthcare is a top of mind of all healthcare security professionals across North America. And today's webinar and panel discussion is all surrounding innovative approaches to mitigating the workplace violence that we're seeing in healthcare, increased violence. If you have any questions during the webinar, please put them in the chat, and at the end of the panel discussion and webinar, we'll endeavor to answer any questions that might have come up during the presentations. We're lucky enough to have a valued colleague and somebody I'm proud to say is a good friend, Tom Smith, Principal President of Healthcare Security Consultants, being our panel moderator today. I'll turn it over to Tom, who will do some introductions and set the table for today's important discussion. Tom, over to you.
Thank you, Jeff. Innovative or tuned up best practices with respect to preventing and responding to workplace violence. I'm honored to moderate this group and look forward to our discussion. Our panel includes Dr. Mark Broussenko. He's a physician that practices at the Center for Addiction and Mental Health, the CAMH for another acronym here in Toronto. CAMH is the largest mental health teaching hospital in Canada. Dr. Broussenko will provide his perspective on workplace violence as a provider. Particularly interesting, we're really interested to know what the providers think in this arena. We're always talking amongst ourselves in the healthcare security world, and it's going to be great to have a perspective from one of the leading providers. Jonathan Acorn is Director of Operations for the Lower Mainland Integrated Protection Services, and Jonathan's going to talk to us about the Services Ambassador program that they have there. Next up will be Craig Crosby. Craig comes to us from the Phoenix Children's Hospital. He has a novel program utilizing K9 in their children's hospital, and we're looking forward to hearing about the K9 and how that works in their children's hospital in the Phoenix area. After that, Paul Greenwood will be talking to us about several approaches in their emergency department, including a violence assessment tool, an agitation pathway, and safety dashboard with flags for higher risk patients. They also have a system-wide behavioral escalation response team and code white policy that we're real interested to hear about how that works and how it's been received in that environment. And then we'll wind up back with Jeff, kind of do a wrap up. We'll review some of the questions that have come up and then turn it back over to Jeff to wrap things up and answer any other final questions from the group. With that, Dr. Broussenko, would you talk to us a little bit about your environment there and at the Center for Addiction and Mental Health, and a little bit about your TIDES program?
Yeah, absolutely. Thanks very much. So, you know, as we were talking kind of in our preparation before this meeting, you know, there's a reality that every healthcare provider, I think, is trained. You know, one of the first things I learned in medical school right after how to introduce myself was where to sit in an exam room when you're interviewing a patient. Because you're trained, unfortunately, in the modern world to anticipate threats to yourself or threats to others, really, at any patient interaction. And the reality is that most patient interactions are fine, and this doesn't happen. But you know, situations where people stop being vigilant are unfortunately such that you know, incidences of harm and conflict do arise. And we know that at least in Ontario and in Canada, where I practice, over the last several years, partially related to the COVID-19 pandemic, probably other factors as well, we've seen instances of healthcare, of violence towards healthcare workers in healthcare settings have gone up quite significantly. And so that can be quite problematic, right? So, you know, obviously everyone wants to feel safe at work. It's also problematic in a practical sense. The provider-patient interaction tends to get a lot more strained when there's been an instance of violence or threats of violence. It's hard to go back and reestablish and reclaim some of that rapport. And so there are a lot of people, smarter than myself, thankfully, who have been spending a lot of time thinking about how and what it would look like to have this be something that you can really address, right? So that this would be something that you can intervene on, and looking for ways to prevent and avoid some of these interactions. So one of the things that we do at CAMH is a very interesting program called TIDES, which is trauma-informed de-escalation and support, to try to avoid instances where patients, especially vulnerable patients, can be triggered and can respond with violence. Because one of the things that we know is that one of the main causes of workplace violence is actually completely internal, right? So these are things that are problematic and triggering for our patients. These are interactions that are unsettling for them, or that can reactivate past trauma. And in a sense where people are emotionally dysregulated and don't know how to respond, unfortunately, their default response is relatively primal and includes violence either towards others, but often also towards themselves or their environment. And those things are avoidable, right? So we can, one of the valuable things is that, almost all of our staff are involved in this program, right? It's not just clinicians, it's support staff. It's everyone who interacts with patients. It's personal support workers and patient care aides, and everyone along the entire chain of patient interaction is encouraged and trained to look at instances of workplace violence as a trauma response, and to see if there are ways that you can de-escalate those situations. So if you see that someone is becoming violent or is threatening violence or is using particular language and or behavioral gestures or things like that are associated with violence, to try to move the conversation away from those topics, to try to redirect them, to give them another activity, or to move them into a different environment that can often be safer for themselves and for others. This largely works, right? I mean, it's not to say that there aren't instances of violence that we don't have code whites. At our facility, obviously, we deal with people who are quite dysregulated and often psychiatrically quite unwell. And so the goal isn't, the aspiration is always, zero instances of violence. But the reality is that we're not going to get there. The goal is to help mitigate those as much as we can and reduce both the frequency and the severity of these things when they happen.
Well, thank you for that insight. What do you see as the biggest challenge facing us related to workplace violence today?
So, I mean, there are a couple of things. One of them is the change and the slow erosion, and this precedes COVID, and this precedes kind of the modern construction of the delivery of healthcare. But one of them is a challenge in the erosion of trust between patients and clients, and the public at large and public institutions. So if you fundamentally distrust the environment that you're in, if you think you're going to be forced to do something that you don't want to do, if you think that they're not acting in your best interest, and then violence becomes a much more reasonable response, right? Like it's very rare, no one's on an operating table getting their broken bone fixed and then starts, punching their surgeon because they don't trust what they're doing. But, in the mental health space, obviously, very frequently people, for reasons largely related to their illness, don't believe or don't trust that the interventions that they're being offered, particularly medication, are going to be effective. And so in that case, when your perception is that you're being poisoned or your bodily autonomy is being infringed upon, violence is a reasonable response. In the population largely, when you no longer trust that your healthcare provider is working in your best interest, again, violence becomes a more common response. I recently rewatched the film Contagion, and one of the themes of that is that the public would distrusted the integrity of the people who are providing care. And if you think you're in bed with large pharmaceutical organizations or some other form of collusion, and your only recourse is violence, you'll go towards that.
Is there a common misperception that you've seen related to workplace violence?
So, a large part of it is that people assume that instances of workplace violence are are large and overt forms of, large and overt aggressions. And if that's the only thing that you count, I think you're missing a lot of other interactions where people can be made to feel threatened, people can be made to feel uncomfortable that don't escalate entirely to a code bite intervention. Obviously, an event that requires the presence of additional staff and security staff and medical staff, and possibly physical restraint is an end of the line event, right? There are numerous forms of aggression that don't hit that threshold, that happen on a frequent basis, that I think really impact staff morale and impact the delivery of clinical care, that people don't track and don't pick up on. So I would say that one of the biggest misperceptions is, in fact, that I think this is more frequent than anyone really realizes. And then the other one is that these are not all of these are predictably triggered, right? So at times you can notice that someone is becoming agitated or violent for an event that you have no idea why it happened. So they might have gotten angry with a co-patient 20 minutes ago, and they're lashing out now. And if you weren't there to see it, you'll have no idea why that level of escalation took place. And so I think a lot of the training towards especially providers and staff is to be less about avoiding triggers and more about recognizing when that has already happened and how to address with that as you can kind of see it manifest in front of you.
Well, thank you for that. Can you describe for us your typical day and how you deal with workplace violence in your organization?
Yeah, so absolutely. So usually we start with interdisciplinary rounds, and that's also when any overnight events or any overnight triggers are noted. So one of the key things is telling people to be primed, especially for people who have a known history of violence, that that they've had a bad night or a good night for that matter, right? If you know that you're going to have a delicate conversation with someone, it's helpful to know you want to catch them on a good day, not a bad day. And so if you're looking for it, that information can help you strategize kind of the level of caution and the complexity of emotional conversations that you're willing to have. And then in terms of providing routine care, one of the things that we do, and one of the things that I make mandatory for my trainees and all of the other junior staff that work with and under me, is that if you have any concerns, don't be in the room alone, right? So I strongly encourage people to go into the room in pairs or with more than two people if that's appropriate, especially if you're going to be doing any kind of procedure, anything that requires a lot of proximal contact. As I mentioned previously, positioning yourself in where you are in the room is, I think, of paramount importance. So, making sure that there aren't object, things like that, in between you and a way to exit an environment where you're providing clinical care. And then the last innovation that we have are, and I wish I had one of these on me, unfortunately, are lanyard-activated security alarms. So they come with a code blue and a code white button, and so you can trigger one remotely to activate an overhead alert for a medical emergency, and also to activate one for a code white, a patient violence incident. And those are tied to the security that's downstairs, and automatically flag a request for security assistance. So everyone in a patient care area has to have one of those on them, and they get tested every morning to ensure that they're working before people end up on the floor. And then this kind of gives you both the peace of mind that you have protection and you have access to help if you need it, but then also obviously it significantly decreases the amount of time between when you're in an uncomfortable situation and help is able to intervene. So that kind of yes. that's kind of a walkthrough of my day and how I interact with both patients in a clinical setting, and also some of the precautions that we take to make it a safer environment and a more supportive environment for our staff.
I think you've given us a pretty good kind of general idea of that, what we call situational awareness, and I think that communication with others on the team is really important about what's happened the previous shift or two, and it's kind of what we already know, but it's important to know that the providers are thinking about that in particular. So thank you for your impressions and for your thoughts today. We appreciate it. There may be a question or two here at the end for you. We'll see.
You're very welcome.
That said, we're Jonathan Acorn. Jonathan, you're going to talk to us a little about the initiative approach, the approach to the client service ambassador program.
Yes, thanks, Tom. And thanks to GardaWorld for providing the forum for the discussion today. So our client service ambassador program is a program kind of envisioned, developed, and overseen by Integrated Protection Services at a number of our emergency departments across the Lower Mainland. I guess I would describe it as a kind of non-traditional, focused on the proactive engagement of patients and visitors to improve the customer experience, if you will. Really to put a human touch, an acknowledgement to connect with people on a human level rather than just as a patient or a visitor or whatever the case may be, and supporting our clinical staff in providing care. So the client service ambassador's role is characterized by respectful, non-judgmental, supportive, people-focused interactions, right? So their primary job is to continually monitor, actively patrol the emergency department, and acknowledged as people, and hopefully recognize or alleviate some of the stress and anxiety that comes with a visit to the emergency department, and developing relationships with our clinical staff, with our patients, especially our regular patients, liaising with law enforcement, emergency services, providing that kind of bridge between the security staff, the clinical staff, participating in regular team briefings with the clinical staff, debriefings, whether they be safety huddles, initial kind of, I don't want to say rounds, but shift briefings, things like that, to help kind of increase that communication between the groups. So that's the overview of the program. Sorry, Tom, you're muted.
Tell me, what's the business case for pursuing an ambassador program?
So why we did this? We're always looking for new ways to address it, just like everybody else is, right? Violence in healthcare has been a long-standing concern, and I imagine always will be a concern. We saw the problem, and we didn't want to just do a reactionary approach, just by throwing more security at it or changing the environment. Well, those are good strategies as well, but we wanted to try something different. So we looked for something to kind of proactively approach the issues. Now, the notion of having somebody in an emergency department to kind of focus on customers is not a new notion. Other programs, other hospitals have done it as well. We thought we'd just try to elevate it to another level. So our ultimate goal was to make a positive impact on safety and security in some of our busiest emergency departments in the Lower Mainland. So that's why we did it. Yeah.
What type of training do you require of the ambassadors? What's different that they get that your traditional security staff do not get?
Yeah. So we typically recruit our ambassador candidates from our more experienced security staff. So they have a familiarity with the environment and with the type of they're comfortable interacting with patients and those kind of things. But we look for specific traits in the individuals. And when we're recruiting from people we know, it helps us get a more accurate sense of who they are as people. When recruiting people for any team, personally, I like to recruit people with the best fit, people that will fit with the team, fit with the role. You can teach anybody technical skills, right? You can teach anybody that, but you can't teach people to be necessarily the type of person you think will fit and complement the role. So kind of that strong emphasis on customer service and support and empathy, understanding of empathy being able to interact with the people we do appropriately. So that's kind of one of our primary roles. They get extensive training in violence mitigation and de-escalation techniques, including so there's a provincial violence prevention curriculum standard in BC. So they go through that. They also go through the advanced team response training. We give them training in cultural awareness, trauma-informed care, and annual retraining of all the de-escalation techniques. And we seek opportunities to get them involved in any clinical education that may be offered. So,
how do you know you're making progress? What do you use to know that something's working?
That's always a good question, isn't it? And the
is.
Default answer is often data, right? And data plays a key role here. And one of the questions we asked ourselves in security industry, you hear the old adage, if you didn't write it down, if you didn't document it, it didn't happen, right? So taking that kind of approach, we didn't want our ambassadors to be running back to a computer to write an incident report every time they did something, right? They'd never be on the floor, right? So we looked at what do we track, right? So how do we demonstrate what they're doing? How do we show what they're doing? And how can we document that while keeping them on the floor? Ultimately, we developed a mobile application, and we started with tablets. We've since evolved to more of a smartphone device. And we developed a number of incident categories. We have 19 interaction categories. 7 of them are related to aggression, 2 to behavioral distress, 5 to clinical consultative, 3 to customer service, medical concerns, and then promotion of security awareness and those kind of things. So when they have an interaction with a client, they can easily just kind of on the form on their device, they can document that interaction pretty quickly. But before we did all that, one of the things we did was before implementing the ambassador, we surveyed the staff. We looked at our security activity data, which we have extensive data across our program. We surveyed the staff. And it was a simple survey, very simple survey. I think the exact question was, how safe do you feel? Right? And we gave them a scale of 1 to 10, allowed comments, that kind of thing. We got those results back. After we implemented the ambassador, another 6 months later, we sent up the same question again, right? And asked them to rate it. Now, the average rating went up by 2 full points on a scale of 1 to 10. So it was a demonstrative kind of improvement to how staff felt in the environment. So that right away told us that we did have a nice impact, a positive impact on the staff and how they feel about being in the environment. We looked at our security incident reports, what types of incident reports were occurring prior. We looked at the number of them occurring afterwards. And we saw a correlation between reduction particularly in the physical aggressive incidents. At some sites, when we did these trials, we got up to 28% reduction in that period. One of the categories we track is what we call successful de-escalation. So they did not have to, if they had an incident where they saw somebody escalating, they were able to intervene, de-escalate the situation without having to escalate it to security. Then that would be captured that way. So, for example, at one of our sites, we saw over 1,300 successful de-escalations. So you could make the argument that if the ambassador wasn't there, if they weren't doing that, we may have seen those as actual incidents where security got involved. Right?
Well, that's very interesting. I think, as we've all heard before, in God we trust, all others bring data. And it sounds like you're doing that, John.
Yeah, thank you.
So thank you very much for the background on this very interesting program. And I'm sure there may be another question or two for you at the end of the program. So we're going to move on to Craig Crosby, Director of Security and Safety Service at Phoenix Children's Hospital. He has an innovative, very interesting program that I'm looking forward to hear about, K9 in the Children's Hospital there. Craig?
Thank you. Good afternoon, Tom. While K9 programs aren't new in healthcare, they're unique in strictly pediatric settings. So I'd like to share a video with you of our K9 program here at Phoenix Children's.
The power of these dogs are incredible. And if you're causing harm or threatening to cause harm at Phoenix Children's, and you see one of these dogs looking at you and barking loudly, you will stop. And if you don't, my name's Rick Black. I'm the security manager here at Phoenix Children's. We are the first children's hospital in the nation to have a security canine program. We currently have 4 canine teams, 4 dogs, 4 handlers. They're trained in protection and the detection of explosive odors. And they all have completely different personalities. Max is a Belgian Malinois. He never slows down. He's got endless energies. Rex, he's our poster child. He loves the attention and he just makes it look really easy. Cowdy, his nickname is Tasmanian Devil. He's constantly wanting to run everywhere and constantly wanting to work. Osco is our youngest dog. He's almost 2 years old and he's a real quick learner.
Hi, my name's Garrett and I'm the handler for Canine Max, and I've been handling training dogs for over 8 years.
Hi, my name's Susie. I'm the handler for Canine Rex. I have 25 years of security and corrections experience.
Hi, my name is Steve. I have 20 years of law enforcement experience, 6 of them handling the canine.
My name is Mark. I'm the canine handler for Osco, and I have 26 years of law enforcement experience.
Jump up at him, he's probably going to bite this because that's what he's.
The training is ongoing, it's constant. We're training all the time. We train with Phoenix PD, we train with TSA, and we also train with the FBI. So when we end up doing training, if you see a handler get out a big tug toy and start playing and wrestling with their dog, it's because we just did a training exercise and the dog found what he was supposed to. So we got to make that play time that much more fun than searching for the explosive, because that's why they do it. They do it in order to play with that toy. They alert, they protect, they search for people, they search for explosives. This is just one more cutting edge program that Phoenix Children's is using for serving our patients, families, and staff.
Wow, that was a phenomenal video. Thanks for sharing that, Craig. Can you tell us maybe a little bit more? What do you think the business case is for pursuing canine programs in hospital situations?
Absolutely. With the dynamics of healthcare security, we're always looking for innovative ways to increase our security capabilities as we carry out the missions for our organizations. There are various security tools, methods, programs. Canine is unique because of the ability to address each level of use of force within that continuum, whether it's from the compliant to the aggravated aggressive subject. In our sensitive pediatric environment, de-escalation, potentially violent scenarios, acting as visual deterrent, psychological deterrent, detection capability, including firearms, strengthen the business case overall for us to pursue a canine program.
Are there common situations you feel that where the canine has helped prevent violence in your organization so far?
Absolutely. In our pediatric environment, emotions run very high. On a daily basis, we respond to Department of Child Services custody cases, child abuse reports, family disputes, human trafficking, level 1 pediatric traumas, and high-profile terminations. The canines also help prevent violence by identifying persons carrying firearms inside the facility and also inspecting unattended and suspicious items.
Well, that's for sure. Those environments are certainly fraught with stress from the patients and visitors that you encounter, I'm sure. And I'll bet the canine seems like it's a very successful program there. How do you measure success?
Well, just as you stated earlier, it's all about data. Annually, we track our crime stats and data for the facility, along with city crime stats from a 1 mile radius around the facility. We've been able to maintain 0 serious acts of violence compared to what's going on around us in the community. We also track number of de-escalations performed and also the number of detections made regarding firearms. Here in Arizona, We're open carry state. Firearms is a big issue for us here. And even though the statute's very clear about where you can take that firearm, where you can't take it, we do have people that forget and bring it into the facility. So having a team that can detect on that has put us in a position to further prevent violence in the workplace. Another form of measurement is really just direct feedback from patients, families, and also overall staff satisfaction.
Do you have a canine on duty at all times, or do you have it for specific time periods during the day?
We do have it. We've compared where we've seen most of our response needed, and so we've tailored our schedule to meet that, definitely around our heavy times in the emergency department, hours, and along with other things. So we do match it up based off of where we see the need.
Oh, that's great. Where should our listeners look to learn more about developing a canine program?
Well, definitely make contact with a healthcare facility with a canine program in your area if possible, to fully understand the program and the local environment, whether it's what the hiring environment is like or just other things that really are specific to that area. And then also through the International Association for Healthcare Security and Safety, there's webinars that are available, which is a great resource for information in terms of starting a program, just gathering more information.
Well, Craig, thank you very much for providing this important information to us today. And as I said with the others, there may be a question or two here toward the end of the program. Thank you. We'll move on with the program to Paul Greenwood. Paul is the Director of Security and Fire Safety at Unity Health in Toronto. He's going to talk to us a little bit about some of the innovative approaches involving their BERT program, their behavioral escalation response team, and the violence assessment tool and agitation pathways. So, Paul, take it away.
Great. Thanks, Tom, and thanks, GardaWorld, for having me here today. I'm actually learning a lot myself, so I'm happy to be here. I think we're all struggling with workplace violence, and at times, I was just writing some notes earlier today, and how many different initiatives have come out over the years in our own organizations that have either gone by the wayside, failed, or found not to do the job. And I think that's something, and Tom, you kind of flagged this for me yesterday when we were chatting, is we haven't been using the tools that reside in our own organizations at time. We're not using them effectively, and we're missing sometimes partnerships and communication. I think that Unity Health has finally got to a place where we are, through our risk assessment tool, our safety dashboards, agitation pathway, and then lastly, the BERT program that you mentioned, we're finally using all of our tools within the building. And just to give you an idea, a lot of our most recent work in our emergency department came after we had an incident last year where a gentleman presented who has a history with our organization, but presented to our ED with an axe. Now, he had shown up twice before that, and on the third time, we actually had paid duty police present. So we were lucky enough that they were able to de-escalate the situation without any injuries or a fatality taking place. But it really triggered a need for better communication. So what we implemented, and this was really led, and I'm happy that I'm here presenting it today, but this could have easily been one of our clinicians presenting today, because it really was a joint effort. But they developed a new violence risk assessment tool. And basically, upon presentation in the ED, every patient has one done. And depending on your score, if you're a 0, then nothing happens. I mean, you enter the ED, there's nothing noted in your chart, and nothing hits our safety dashboards. But if you do end up having a mid to high score based on your presentation or based on a previous experience with you as a patient in the hospital, then immediately that goes to our safety dashboard. And what that is, it's an actual screen that's in our security office, it's at the triage or registration desk, and in the different areas of emerged nursing stations, where they can see every patient who's on our safety dashboard who came in with a high assessment rating. It actually shows which bed they're in, and it will move as the bed, if they happen to move rooms, it moves with them, so that we know, our staff know that they can pay a particular attention in an area. And it also allows our clinical staff to prepare before going into a room, to make a plan before dealing with that patient if they are at risk. So that talks a bit about the safety dashboard. The partnership that came in there was between us, security, the clinical team and also our IT department. It took some time, but getting all persons on the same page and making sure that IT could make that happen for us, it really worked out well. Because in speaking with the Ministry of Labour here in Ontario, one of the biggest things they've said about workplace violence is making sure that your staff are aware of the potential for violence. And it is very difficult to make sure you get real-time information to your staff that may enter a room with a potentially violent patient. So we've tried to make that as available as possible in the ED, and then we hope to roll that out through the rest of the organization in the future. The last point about the emerge is our agitation pathway. Now, this is being led by one of our physicians at St. Mike's, and what they're looking at there is to actually, we found that not every physician, every nurse, every security guard that presents at a code white or an agitated person situation handles it in the same manner. It's very diverse. From some physicians wanted people removed from the emergency department right away, where others were giving people time to de-escalate themselves or with the help of others. So we decided to develop an agitation pathway so that when physicians arrive at a code white, for instance, in our triage area, there's pathways available to them that they know, and based on the behaviors of the person, how successful de-escalation is, little things. Do we move them out of the main waiting room and have a different space where that they could wait to calm down? Do we engage social work? Because a lot of I'm not sure if it's the same in everyone's organization, but a lot of our code whites happen when we're trying to discharge people out of the ED. So do they have access to the social worker and come up with immediate discharge planning? Those are the type of things that we actually wanted on a pathway that people could be trained on, have it available, and that they could review quickly to make sure that the best experience for our staff, protecting them, but also for our patients, so that we don't have to engage them in what might turn into a violent incident. Just a quick overview of the BERT program. It's not something new, and it was new to me. And when it was announced here at Unity Health that they were creating it, I had never heard of BERT before. And it turns out that our mental health clinicians, visited the U.S. at a conference, and during that conference, they had seen a great presentation on how BERT teams have been successful in hospitals and help mitigating violence in the workplace and actually preventing it by early interventions, which is something that was missing in the past. And it's been it's a new program rolled out in April of this year. So we don't have I know Tom's going to ask me later probably, how do I track that? What's the data on it? But we don't have a lot of data yet. But it's a great new program that sees our mental health clinicians actually leave the confines of their areas, whether it's inpatient mental health or the emergency department, and actually go out and support our different clinical units where they may have patients that are in crisis, or patients that actually might be a mental health patient, but they have medical needs as well and are being seen in different parts of the hospital. So that's where our BERT team is responding to.
Well, thank you, Paul. I do have a couple of questions, and you stole one away from me already.
Sorry.
What was the violence assessment tool? Was that something that you adopted from some other organization, or is that something that was developed internally and validated somehow internally?
It's actually been adopted from the Emergency Medical Service Violence Assessment Tool. That is what the clinical team used for it, and yeah, it's been very successful. Part of it, and I'm sure the challenges are the same in every building, is getting everybody on board to do it. But there has been increased buy-in. They're seeing the value, they're seeing the early warnings, they're seeing things end up on that safety dashboard. So it's been pretty successful in the last, I think they rolled it out in December, I want to say. And so in the last 3 or 4 months, we've seen a high uptick in people using it, and they're making it mandatory.
I know you mentioned something about the use of the flagging system, and that's very interesting to me. And because the best predictor of future behavior, and everybody knows the answer to that question, what's the best predictor of future behavior? It's past behavior. And so having your staff have the knowledge in advance when some adverse events happened in the past, it's very good for them to know what may have happened with this patient earlier on in their stay or in past incidents of violence in your facility. So it's really interesting.
Definitely one thing that we've sorry, go ahead, Tom.
No, please go right ahead.
I was just going to say that one thing that I did fail to mention is that it is necessary, though, with that violence assessment tool, is to revisit it. because someone that came in your door in crisis may not still be at that same level of score or agitation later in their stay. We find that quite often, that people come through the door, they're in a panic, they're in crisis, they may be suffering with addictions, withdrawal when they come in the door. So it's always important for the staff to reevaluate that during a person's stay, or even evaluate them from the past to make sure that they're that doesn't stigmatize them. We don't want that happening either. So it is necessary to reevaluate the patient during their stay, whether it's in the emerge or elsewhere in the organization.
Well, thank you for that clarification. I also am very interested in the BERT that you have, because I see BERT programs in most major organizations. Either they've been around a while or they're starting one up, but there's a vast degree of differences in who responds and what locations they respond to. But in your case, can you give us an idea how often the BERT's utilized and where is it most often deployed?
Absolutely. As I mentioned, it just actually started. We rolled it out April 4th, to be exact, was the first day of the BERT program. And the team that's responding is from our inpatient mental health team. Right now, it's only running 8 hours a day, which is not optimum. It really needs to be a 24-hour support team. But with funding, they're making the case by starting it with 8 hours. And what we've seen right now is that we've had 20 calls for assistance in the month of April. With the majority being in I found this was a surprise to me, but within our med-surg ICU. And that was where the majority of the calls were from, followed by our general internal medicine floor. Now, with the general internal medicine floor, that's always been an area of high code whites for us. It's quite a diverse population that we get up there. So we've always had a lot of the code white experience in those units. The MS ICU was relatively new to us. And that why they would be supporting it. I think that the key there was that their team is bought in to calling for help when they have a patient that they're recognizing is in crisis and could benefit from the BERT program. So I think their clinical leadership has done an outstanding job in rolling that out to their team and encouraging them to use it. So we're hoping to see higher numbers in the other departments as the months go along.
I do find a lot of valuable input, particularly for units that don't traditionally house emergency department patients or victims of violence or behavioral health patients, where those BERT teams are available to help clinical staff that aren't used to managing those types of situations. So I laud the efforts in BERT, and I'm certainly a big proponent. What training do BERT responders receive? And then kind of follow up, how do you get buy-in from the responders? How do you get them to participate?
The training, it was interesting to me. Actually, I had to reach out to review that, and what was interesting was that on top of their normal, the clinical mental health training that they get, which includes de-escalation training, etc., they actually are now all of the team for the BERT program are actually being trained with our colleague that's on the roundtable today. Not with him, but with the center with CAMH for the Center of Addiction and Mental Health here in Toronto. So they're taking the TIDES program. So kudos to CAMH. We know it's an outstanding program, probably a program that a lot of people could model their own response programs by. So we're actually sending them there for training, and that's the addition that they're getting. Buy-in. So this goes back to partnerships. We've reached out over the years. I've been at St. Mike's now for 17 years, or UND Health in total for 17 years. And there wasn't always buy-in to have our mental health teams respond out of the unit to assist elsewhere. And then a few years ago, they developed something called the critical care response team that helps in critical care situations respond to different units and provide that support, provide expertise. And then we had a change in clinical leadership in our ED program when we merged to become Unity Health. And the new leader thought that's right. Why can't we do that? If they can do it for clinical medicine type events, why can't we do that and provide mental health support across the entire hospital? So the buy-in started with her. And it's been amazing, because not only are they formed a BERT team, but they also are now responders to our Code White programs that we just launched, a new Code White program. And the response team includes a mental health nurse responding to every Code White in our hospital. It doesn't matter where it is in the hospital. So having that layer of expertise, bringing somebody a different set of eyes in, it's not just a medicine team and a security team, has been outstanding. And the teams really support that, the expertise they can bring to the table.
I think that concept is, it makes great sense if you can have a code team of multidisciplinary response members, and many places have an IV team, a special team of people that just do IV. It makes great sense the BERT teams having something similar, because you have all that expertise, and most larger organizations have the expertise, and it's just a matter of utilizing it, and not just sending the uniforms to these situations, because we know sometimes our clients and patients don't respond as well to a uniform as they would with a clinical approach first, with support from uniformed staff members.
Absolutely.
So that kind of rounds out. I thank you very much for the great information about this team. So that said, are there questions that we've received? I'm interested to see if we have any outside questions, and we can kind of see if we can stump this panel here with some really hard questions. If there are no questions, we'll turn that over to Jeff. And Jeff, maybe if there's a question or two that okay, here we go. I got one. Okay, Craig, this is for you. Does the canine program differ, given that it's a children's hospital? And kind of another follow-up is there a therapy component to it as well? And that I sort of had that same question as well. So does it differ for children's hospitals, and is there a therapy component?
It does. I'll start with the therapy component. It's not an official therapy component. We do have a pet therapy program as well. And so that's a little bit separate from what we do. In terms of a different component to Children's Hospital, it definitely is. When we were looking at starting our program, we took an extra look from a risk, from a legal standpoint, and making sure that we had the right dog for our environment. A dog that's going to be okay with children running up to it at times, or being in other sensitive situations. And so that's something we really took a close look at in terms of how a canine program would work in a very sensitive pediatric environment.
Excellent, thank you. Are there any other questions that we've received? That was certainly one I had already. Jeff, I think I'll turn it over to you to wrap us up, and I thank the panel for being here and putting up with all my nosy questions in the run-up to this program.
Yeah, thanks, Tom. And just to echo your sentiments, I'd like to thank all of the panelists as well. This has been a great panel. We do have one more other question just came in. Tom, if you will, I'll just continue and maybe ask the doctor.
Yeah. Sorry about that. I was trying to unmute myself. It's a great question. So, one of the conversations that I try to have with patients and families is to emphasize the fact that the delivery of a lot of healthcare feels adversarial for people, because often the healthcare setting is a place where you also interact with other government agencies, where you interact with some of the tensions of various support programs. Especially in the mental health space, many of our patients are on various forms of community treatment orders, or are found, incapable of consenting to some of the decisions that are happening to them. And so there's definitely that presupposition of challenge that it's us versus them. But one of the things that I often start by emphasizing, especially with people who have a history of violence, is that it's not meant to be punitive. It's not, the interaction isn't meant to be hostile. I'm not trying to get them to do it or say a thing, and then that's then going to escalate the situation. And then that's going to move them into various forms of confinement, or the use of chemical or physical restraints or anything like that. Like this isn't a school setting. This isn't a jail. This isn't a corrective setting. It's not my desire to really change their how they feel about it. Really, what I start off is I'm trying to find ways of working together with them. And so I'll often ask people, what is going to be important to you about this interaction, right? Who do you want here? What kinds of conversations do you want to have? What kinds of words do you want me to use? And, obviously there are exceptions to this. Some people are quite unsettled. Some people are quite unwell. Some people are not going to be negotiable. But in general, I'm happy to accommodate almost all of those. Right. So if someone wants to be called a different name, if someone, wants the lights to be dimmed, if someone wants a sandwich before they talk to you or something like that, I'm usually really happy to accommodate those. And start that conversation by trying to make it collaborative. But then I'm also very realistic about what the goals are of any particular interaction. Right. So if someone's goal is to be discharged in their on one of several legally binding forms that in Ontario, I'll just communicate to them that that's just not happening. And then so their expectations of the interaction change such that we know that we're both talking about kind of the same thing, and that we're both talking about reaching goals that are going to be realistic. And then the last thing, this feels maybe a little bit counterintuitive, but it's often recognizing when people aren't in a place or aren't willing to talk. So again, if someone's very dysregulated or very violent, especially in the setting of recent substance use, sometimes you have to know when to sometimes you have to know when not to play. And so if they're not going to be in a position that they're ever going to be interested in talking to you, leave. Right? Like if not getting anywhere, I usually call it quits pretty quickly, and then I obviously come back and I do a reassessment at a time that they're more settled. But I historically haven't found that I have a ton of success, especially with people who are extremely psychotic. I haven't found a ton of success in prolonging those conversations past when anyone thinks that they're necessary. So those are kind of some of the strategies, and hopefully they're helpful for other people in this context.
Thank you very much for that added information, and I'll turn it back over to Jeff.
Yeah, thanks. That was great. Thanks, Tom. Again, just my thanks on behalf of GardaWorld to our panelists today on innovation. When we're dealing with the increased violence in healthcare, I think what I've learned or just reiterated to myself is, there's really no silver bullet here either. There's no one-size-fits-all program, and I think for today's session to be successful, I think if our audience just got one nugget here today that they can take back to their hospital or their health organization to help mitigate violence in healthcare, I think then this has been a successful webinar. I think we've got a great panelist with some great, again, innovative ideas, and it just comes back, and I've heard this couple of themes throughout, taking that risk-based approach and creating that overall all-staff culture of security and safety to support, the safe management of patient-initiated aggression, and that transfers into better patient care and transfers into better outcomes, but it also transfers into staff satisfaction too. We heard John talk about, do I feel safe at work, which I think is a very important component that we need to recognize. And all that said, though, we cannot solely rely on security staff to manage or mitigate aggression. It has to be a multi-team, multi-discipline approach. And I've heard some great ideas, and Paul talked really great about how they integrate with the clinical teams and how they're working together to help mitigate aggression. And just, and I've heard again, another theme too is that we really need to get better at recognizing and intervene at the earliest signs of aggression. So when we recognize agitation, or we talked about, patients that present that have a history of aggression or violence, really flag those and be able to mitigate that aggression. And again, that's a multidiscipline team. We need to work together with our clinician partners. And then, those that know me, I'm a real data person, and we talked about data a few times here. And, it's important to drive your program, your violence mitigation program, your security program, if you will, to being more business-like and support the data, have the data there to support, your financial programs to mitigate aggression, and for you to demonstrate the return on investment. We talk about that too all the time. So have the data to support your program and to drive your program so that you can come up with some of these mitigation strategies that we talked about today, because a canine program is not free. An emergency department client service ambassador program is not free. The programs that Paul run are not free, and those, they have a cost to it, and we have to be, especially in healthcare, those dollars are not, they're finite dollars, and every dollar you spend on security is potentially a dollar taken away from direct patient care. So we need to spend those dollars very wisely. And I think we've got some great ideas here today that I'm hopeful that folks will take back and think about for their organization. So again, thank you to everybody. It was a great time for me. I learned things, and a lot of things went off of my head. So it's a good thing for me. So Tom, thank you on behalf of GardaWorld for agreeing to. Much appreciated, and thank you everyone, and be safe.